my approach to many procedures, especially the ACL, patella instability, and meniscus injury. Surgery, just a great quote from Jack Houston about you want to pay attention to your anatomy lessons because most of what we do, quite frankly, is anatomy and hopefully not just a little bit, but maybe a lot of common sense. I've had this pediatric anatomy journey that's been just over 20 years now, and part of it started out where I started tracing digital images of MRIs to create three-dimensional models. We didn't have software back then to create 3D models, and this led to some surgical simulations with relatively crude engineering and incredibly expensive software. We'll go through some of that, but really painful, and it's so easy to do it now. I tried for a long time to get pediatric knee specimens. They were impossible to get both in Europe, India, and the United States, but in 2010, I got one specimen. I flew into Colorado with two other colleagues, and we spent the day dissecting an 8-month-old knee specimen. And over the next few years, we got more specimens, and now we're getting 20 to 40 specimens a year. And I've dissected well over 300 pediatric cadavers over the last 12 years, which is the basis of a lot of this work, and it's led to about 60 publications in various different areas. This includes all the ligaments that we all commonly know, both the anatomy, development, vascularity, and most importantly, the physeal relationships, so we know how to do surgery safely. I've done a fair amount of work thinking about graft options for pediatric adolescent patients, including the development of maybe a new graft, something called the bone-tendon-periosteum, perhaps sometime in the future. Thought a lot about LET, anterolateral capsular procedures, including the anatomy with relevance to pediatric cases, and all blood supply of the knee joint, including the etiology of OCD. Doing a lot of work now on meniscus development and vascularity and some repair transplant work, and really interested in the medial patellofemoral complex, both the MPFL and the MQTFL, and launched in a new area, including the development of the trochlear and patella, and maybe some work on patella tendon transfers that don't damage the physis. So some of the things we've learned about ACL, including the anatomy, relationship to the physis, graft options, and ALL LET procedures, so we'll go into some of that. For those of you in the audience that haven't been doing orthopedics as long as some of us, there was a time when you were told not to do ACL reconstruction in kids because of damage to the growth plate. And there's lots of documented publications or documented series of risks of growth plate disturbance. And here's an example of one, even in 2013, significant shortening varus recurvatum, valgus deformity. And we do know from some of the research that if you have a small volume of physeal injury, maybe less than 3%, risk of growth plate arrest is smaller, but over 7%, the risk is higher. It also depends on the location as well. We do know in the pediatric guided growth world that you can easily produce 2 to 10 degrees of angular change about the knee in 1 year with physeal injury. So that's a pretty big problem in ACL reconstruction. One of the questions I had, right out of my training in the early 2000s, can we minimize the risk of growth plate arrest with certain choices in how we perform drill holes? And so this is some of this manual measurements where we actually traced MRI images and then put them into a computer to create three-dimensional images. This is all manual tracing. And I found that there's a couple things you could do. If you wanted to minimize the damage on the tibia side, a more medial starting point was less damaging. A more inferior starting point was less damaging. Obviously, a smaller diameter hole has less volume of injury to the physis. A steeper angle would give you a more of a circular injury as opposed to a less steep angle, which gives you more of an ovoid injury. And you really want to avoid that peripheral perichondral ring area because that's probably the most vulnerable to growth plate arrest and growth disturbance. And these are just some additional, very crude 20-year-old images that we had to do manually to model the physis, the epiphysis, and the tapsis. And we kind of developed some ideal drill holes. So if you're drilling through the tibia, if you hit the center of the physis, the risk of a growth plate arrest is small. The non-ideal drill holes where you hit the periphery of the physis and damage the perichondral ring, and this has a much greater chance of causing growth plate disturbance. So you want to avoid that peripheral position and that larger volumetric damage to the physis. We also did some modeling of growth plate injury on the femur, showing that certain orientations and certain sizes of drill holes were probably below that 3% threshold, but above certain thresholds and in certain positions, you do enough damage, you're going to cause growth disturbance. We did some modeling work on this, once again, crude modeling, because that was all we had at the time. These are engineering models. But I really felt that I needed some knees. I was trying to find where can I get pediatric knees to really study this work, and extensive search, writing people all over the world, including India and Europe. We couldn't get any knees. And then suddenly in 2008, we got our first knee through a lab in Colorado. It was an 8-month-old knee. And we know that the ACL embryologically, by about 10 months, it really does have its adult structure. And it's very distinct from the PCL. By about 20 weeks, the ACL in a kid looks just like it does in an adult. It's just smaller. This is one of our pictures from one of our early dissections. You can see this. We took some bandsaw and to show this physis. And if you look, here's the physis right here, very clearly outlined. And this here would be a drill hole for an all-epiphyseal drill hole. So if carefully placed, you can avoid damage in the physis. But this is a typical adult drill hole orientation where you have a cylinder going right through the physis, right on the peripheral area, and right near the perichondral ring. So much more risky in terms of causing a significant growth plate arrest. We know the origin of the femur primarily has a broad oval shape, and it is smaller though than the tibial attachment. The tibial attachment is more broad. And if you look closely, both on the anterior medial and posterior lateral bundles, you can see it's quite close. And we actually studied this in the infants under a year of age, and we found the average distance from the center of the ACL to the physis was 6.3 millimeters. But then we looked in the 18, 11-year-old, and we found it was only 8 millimeters. So not a big distance, not a big safety zone. And these are some of our publications on quantifying the distance with respect to age in terms of center of the ACL to the center of the physis. And so just to caution people that in that 8 to 11-year-old, you may be only 6 to 9 millimeters of center of ACL to center of the physis. So there's not a big margin of error. We'll show some diagrams on this a little bit later. When you're thinking about doing all-epiphyseal ACL reconstruction, which does employ drill holes in the femur and tibia, this procedure has been described by Alan Anderson in that 5 to 15-year-old age group. Ted Ganley in Philadelphia has done some modifications of this with some different drilling approaches, but there's been an evolution in my own practice and by Ted Ganley and Alan Anderson as we did these dissections through the years. Alan initially did these all with full-length tunnels. There's some advantage to that, but we did find that there's a much greater risk of peripheral physeal injury with a full-length tunnel. And so we started to change, and as we were in the lab, we started looking at the risk of physeal injury when you use a short socket. And obviously, there was a much less risk of physeal injury if you used a 15 to 20 millimeter socket. In the Lizard world, we talk about SARs or structures at risk when you're doing things for deformity correction and trauma. And the same thing I think applies when you're doing all-epiphyseal ACL reconstruction. And there's radiographic landmarks that'll help guide you to avoid those structures at risk. And by using these guide marks, you can avoid direct injury to LCL or anterolateral capsule or popliteus, because I think it's really important that we not damage those structures. We have a CT scan database of over 100 pediatric knees now, so it's allowed us to develop these very nice models and also overlay the ALL, the anterolateral capsular structures, the popliteus, the LCL, and the physis. And these are structures, obviously, you want to avoid, as well as the articular cartilage when you're drilling full-length tunnels on the epiphysis. The CT scan database allowed us to really carefully define the relationships between these ACL structures, but also the lateral capsular structures, the popliteus, and other things, and allows us to kind of provide some recommendations about where to put your drill holes, both starting point in the joint and when you're exiting on the knee, where you want to put your pin, starting point and end point, and not do secondary damage to other structures. Had a lot of discussions with Alan Anderson. I don't know if any of you knew Alan Anderson, a wonderful teacher and mentor of mine. He passed way too early in a tragic farming accident in 2017, but we did a number of dissections together through the years. And it led Alan to change his full-length tunnel technique to the socket technique, because we showed definitively that you can lower the risk of directly injuring the physis and causing growth disturbance by doing the sockets. And in fact, with a socket, you can completely avoid the lateral collateral ligament, the ALL, and the popliteus and the cartilage. And so Alan, once again, changed his technique during these dissection sessions from full-length tunnels to sockets. Frank Cardasco and Dan Green and their colleagues have done some really nice work at looking at these structures at risk on some of their clinical patients. And 14 of their patients, they looked at the all-epiphyseal ACL technique, the Anderson technique, and they showed that relatively low, 1 of 14 had evidence of physeal injury and physeal growth problems on the femoral side. And I think of the femoral side as it's kind of like shooting targets. It's a bigger target. It's an easier shot. So if you think about it, you got a big target, femoral epiphysis, and a relatively large zone to avoid hitting the physis. And so it's an easier shot. It's nice when you're shooting targets to have small bullets and big targets because you look like a better marksman. The tibia, though, unfortunately, is the opposite. They looked at their first 14, and 13 of 14 cases, they caused direct damage to the physis despite their attempts not to do so. And I think that's partly because the tibial epiphysis is a smaller structure. And the drill hole, unfortunately, as a proportion of the epiphyseal size on the tibia, is much bigger. So it is a smaller target with a bigger bullet and a smaller shot. So it's harder to hit the center of the bullseye. It's easier to hit the periphery of the bullseye or damage the growth plate. I think one of the keys about doing pediatric ACL reconstruction, especially if you're going to do drill holes, is that OR setup. And I think the large C-arm is really a handicap in some ways. I encourage people to use a small one because it's much easier to get really precise views close to the knee, and you can move it yourself much easier than the technician can. You can quickly orient for perfect AP and lateral to avoid structural injury. The other thing is that most of the time when we do diagnostic arthroscopy, we're looking from the lateral portal at the ACL. But when you're drilling on kids, you have to drill from the lateral portal. So you've got to get used to looking at it from the medial portal. So I'll frequently, look medially, not just laterally, because that gives me a better understanding of the ACL. I try to obviously confirm the ACL tear, but I like to preserve as much of the femoral and tibial remnant as possible. But also that allows you to really see where you want to put the center point of your drill by aiming on the residual fibers on the femur, as well as the tibia. You can also palpate that posterior intercondylar step off behind, so you can make sure you don't have a blowout to the back. But that medial view, which is a little bit different for most arthroscopists, is pretty important as you're doing this procedure. And that basically is our target of ACL based on where the fibers are and where you want to put your starting point for your drill hole. Here's the drill guide in place. You can see this has to come in through the lateral portal, so you have to view through the medial portal. So it's a little different view for most ACL surgical reconstruction. Instead of drilling with a larger pin, I take a small beef pin because it's a smooth pin. If I hit the physis, I'm not going to cause as much damage. So here's an example of, I got the pin a little too high. That yellow is the growth plate. So that's the guide pin. We're going to drill a larger hole over that guide pin. So that's too high. And that one's a little bit too low. And here we are just in the middle, and that's just about right. And then we'll over drill that. I then advance the retro drill manually, just slow pressure across and through that drill hole so I don't veer off my course. And so you advance that in, and then you deploy your flip cutter, check to make sure it's in the position you want in the joint, and then you flip your blade and do your reverse cut. Instead of doing a full-length socket, you can do these retro drills where you actually back out the drill, and I usually preoperatively plan, do I need a 10, 15, 20 millimeter socket, but rarely go any longer than 20 based on the size of the child. Here's a great example of why you want to look here, and this is an example here of a cadaver that we did this on. This line right here, we thought we were safe. Guess what that is? That's the lower edge of the physis. So you think you're safe, but that's how close you are to the physis. That little line right there is the physis, so you can hit that if you're not careful. Now, we just talked about the femur wrist. This tibia also has the same wrist, and once again, you can use these important operative landmarks to avoid injury to these structures. And here are some three-dimensional pediatric knee models from our CT database. For all pipsal drilling, if you start too low, you're going to hit the physis or the apophysis. If you start too high, you hit the meniscus root, the anterolateral root. And the more shallow your angle is, the higher your starting point. You're going to have an elliptical aperture, and you might even enter the joint and have a blowout and lose your fixation. So it's a narrow zone of approach here. We did a lot of work with Alan Anderson, who developed this procedure, and he would talk about how if you wanted to be as close to the patellar tendon as possible, and you see in this model there, as you get more medial, your apophysis, epiphyseal height gets smaller, and it's much easier to hit the physis and cause a growth plate arrest. And so you have more space as you get more medial. So Alan Anderson said, get as medial as possible, get as close to the patellar tendon as possible, because you've got more real estate and a greater space between coming out superiorly and blowing out, or coming out inferiorly and damaging the physis and causing a recurvatum deformity. Here's actually a pediatric knee, and I'll just highlight the blue arrows here. That's the physis. The joint line is right there at the yellow arrows. You can see there's not a big space there. That's a very narrow window for drilling. And so here's the drill hole that avoid the physis. It's not into the joint too high. It's not too low and into the physis. But this one, probably 15 millimeters lower, crosses the physis, which you don't want to do in that location. So to talk about this overlap of the anterolateral root, and the more shallow your drill hole is, the greater the risk of injury to that root of the meniscus. And so if you've got a shallow angle, you're going to see how it can damage more of the meniscus. So here's a pediatric knee. There's the anterior hornolateral meniscus. And with a steeper angle, more vertical angle, which gets closer to the physis, you have a rounder aperture or a circular aperture, less risk of root damage on that lateral meniscus. But as you get a more shallow angle, that hole goes from round to more ovoid to quite elliptical, and this puts you at risk for having a joint service blowout. So it's a fine line between too steep and too shallow. You got to be careful when you're doing that. I think pediatric epiphyseal ACL reconstruction remains one of the more challenging technical operations that I do, especially if you're trying to avoid the physis sparing with the stall epiphyseal drilling technique. But you really need to have an open conversation with all the parents about the risk of physeal problems, because although it's not common, it still is common enough, probably at least a 5 to 7% risk of having some type of physeal injury and perhaps a physeal growth disturbance, and you want to let families know about this ahead of time. The tunnel drilling really has some big challenges anatomically and does introduce the risk of causing growth plate problems, especially in that smaller 5-year-old, 7-year-old, 9-year-old kid. So keep that in mind when you're drilling there. There are other structures at risk, as we've outlined as well, not just the physis. So as the kids get a little bit older, you can change your procedures. There are some other things you can do. Michele Coker, in recognition of the damage to the growth plate, he developed this procedure in which he did over the top on the femur, over the top on the tibia, so no drill hole damage whatsoever. So you avoid the physis almost completely. This has been shown to be a very good procedure with a low failure rate, excellent biomechanics, but there are some anatomic concerns about the over-the-top anatomy on the femur and tibia not being very anatomic. And the biomechanical concerns, it's also been shown to have some over-constraint because it's a very tight ALL reconstruction part of that, so it does artificially over-constrain and limit rotation, but it acts like an LAT, which is a fashionable procedure right now for ACL reconstructions. Getting the right graft size sometimes can be challenging because the IT band can be very small. A question that I had as I was doing the procedures and dissecting knees is, what's the risk to the neurovascular structure? Because I was a little bit anxious and I was passing that clamp behind the joint, and so that led to another anatomic study. This is a 3D model of a pediatric knee printed here with 9-year-old from our CT scan database. And that clamp, that second picture on your right, shows that clamp passing behind the femur through the notch, through the arthroscopy portal. So we actually looked at this in pediatric cadavers where we actually passed clamps. And I'll call out this red arrow is the tip of the clamp. The red is the neurovascular structures. Right here, here's the artery. Blue, that's the nerve. So you can see how close you are with that clamp right behind the knee doing this over the top position. So clearly has some risk. And I'm just going to play a quick video here. And I guess no audio. Anyone have any tricks about getting the audio to work? Well, I'll just describe what we're doing here. This is a clamp passing behind the knee, assuming this was placed arthroscopically. And that clamp goes out the back of the capsule, out the back of the knee. And you want to keep the tip of that clamp as close to the bone as possible as you're doing so. And my finger there is highlighting the back of the knee. This is the cut area of the femur, but we're going to rotate this knee up and we'll show you the tip of the clamp right there. And then these 3 sutures are on 3 different structures. The first one there, that's popliteal artery. You can see how close it is to the tip of that clamp. The next one is the tibial nerve. Once again, quite close to the tip of the clamp. The next one is the peroneal nerve. And you can see all 3 of these structures are less than a centimeter away from the back of the knee. So not to make you paranoid, but you probably want to be a little anxious when you're passing that and make sure the tip of that instrument does not deviate posteriorly and wrap itself around a nerve or an artery back there. Here's a picture from the lab, also measuring the distance. Green is the artery. Green is the tibial peroneal nerve. Red is the artery neurovascular structures. Blue is the tibial nerve. So that tip of the instrument is not very far away as you're passing that. And these are the measurements based on under the age of 8, 9 to 10, 11 to 12. You're about 0.7 to maybe 1.7 millimeters away from the artery, depending on the age of the patient. So keep that in mind when you're passing that. Keep that clamp close to the bone when you're passing it. Now, as kids get older, your surgical procedures once again change a little bit more. If you've got more than, say, or less than 3 or 4 years of growth remaining, many people will do an all-epiphyseal drilling on the femur. It's a big epiphysis, the risk of physeal injury is low. Transphyseal drilling in these older patients, as long as you hit the center of the tibia, is probably relatively safe because it's a central drill hole. You don't want to put your fixation devices across the physis, and you don't want to put bone graft across the physis on either the tibia or the femur to avoid that growth plate arrest. When there's about a year and a half of growth remaining, you may be able to treat them just like an adult, maybe that 13 to 14-year-old skeletal age female, 15 to 16-year-old skeletal age male. There's still a little bit of concern about if you do transphyseal femur and tibia in this age group, you maybe not want to put a bone graft there because a year and a half of growth may still cause a little bit of deformity. So let's talk a little bit about graft choices. Hamstring has probably been the most commonly used graft in kids because we don't take any bone, we don't get damage to the tibial growth plate during harvest. The bone-tendon bone would put bone graft possibly across the growth plate, but more importantly, it injures the proximal tibial physis during harvest. So that's a real probably contraindication in kids with lots of growth remaining. Quadricep tendon, especially that without bone, is emerging as a good graft in the pediatric world. And I'm also going to talk about a new graft option that we've been looking at here called the bone-tendon-periosteum or the patella tendon-periosteum graft that doesn't damage the physis. So we know that it's probably best to have a good soft tissue option. So that might be a quadriceps tendon or a hamstring. The limit with hamstrings, though, is the size is an issue for re-rupture. 4-strand grafts are frequently below 6.5 millimeters, 7 millimeters. And there's some data showing that grafts at 8 millimeters and bigger are just as low a failure rate as BTP graft, but if the graft diameter is less than 8 millimeters, there's a higher rupture rate. The quad tendon looks like a very good graft in terms of size and biomechanics, and it may have a lower rupture rate than hamstring. We still need a little more data on that. And we're going to talk about a patella tendon-periosteum grafts and some current biomechanical evaluation stuff we've been doing. Let's talk a little bit about the quad tendon anatomy. There's a very clear relationship between the rectus tendon where it separates from the rest of the quad tendon, and that's typically. Let me rearm this mic. That is typically about 3 to 5 centimeters above the patella. And in the pediatric world, we used to do rectus transfer tendons or rectus transfer procedures for spastic cerebral palsy. And so in the pediatric world, we really understood that rectus separation from the rest of the quad so you could transfer it to the back of the knee. One of the concerns I had when we first started doing quad tendons about 15 years ago is, was there a risk of rectus tendon retraction after quadriceps tendon harvest because you're potentially releasing that rectus tendon with your harvest? We do know that quad weakness is one of the biggest concerns after ACL reconstruction. And from the pediatric world, we know that the rectus tendon probably offers up to 27% or a quarter of the strength of the quad. So if you release the quad or recess the quad, you might end up with a weak leg. I took care of a number of skiers, both in Idaho and with US ski team, and saw several who had had isolated rectus ruptures. And I was impressed with how remarkably weak their quadriceps was after that, especially for skiers. Nick Jure, I think, had to leave, but he ruptured his rectus a few years ago and has done quite well. And then he's got a bulge in his thigh from that. But in mogul skiers and some high-level skiers, they really don't like that 25% quad weakness. I think we should be cautious with the quadriceps tendon harvest to really make sure that we understand that separation 3 to 5 centimeters above the superior aspect of the patella and avoid either a recession, a partial shortening, or even a release where there was significant shortening. Because I think there may be risks for both either early or maybe delayed rectus tendon retracture. In Idaho, they weren't my own patients, but I saw 2 patients who developed quad weakness and rectus tendon retraction after quadriceps tendon ACL grafts. And so I have seen this. I've not seen it published in the literature except for one case out of India. So it's probably a rare problem, but as we do more quad tendons, we might want to keep that in mind. So I really like to emphasize that I think it's important to carefully close that proximal interval when you're doing that quadriceps tendon harvest. And here's just some anatomy studies showing that here's your rectus tendon, completely distinct and separate from the rest of the quadriceps mechanism here. And so just diagrammatically, you can see the separate of the rectus tendon, this blue arrow. You want to close that interval. And then here's another little diagram. This interval here probably needs to be closed so you don't have rectus tendon recession or retraction. So I want to call out Mark Sanchez and Anshel Gupta. I'm not sure if Marcel is in the room. Hey, Marcel. Great. Now, this is some really remarkable work that Mark and Marcel and Anshel did. And this came from when years ago, there was an adult bone-tendon-periosteum option. They would take the bone and patella tendon from the tibia with a tibial bone block. But then they started saying, well, let's just peel it off the patella so we don't have the risk of patella fractures and that patellar anterior knee pain. So this was sort of a bone-tendon-periosteum graft. And I looked at this years ago and I said, wow, why don't we flip that upside down and do that on kids? We would take some bone potentially from the patella, but peel the periosteum off the tibia and not damage the growth plate. And so we kind of thought, well, this might be an option. Could we develop a new graft option or revision option for pediatric patients and not damage the growth plate? I'll just play this video. I can't get the audio in here, but I'm going to show you how if you do a bone tendon bone graft in a kid, you're going to see us open this up. So there's the backside of your patella. You can see those vertical cuts in the bone, but I'm going to open this up and you can actually see there's purple marks inside here as I lift up this bone graft. That's something Marcel and I did together, but purple lines in there show the tibial physis. And so if you harvest a graft from here, you directly damage that proximal tibia apophysis and physis, and that's a setup for a recurvatum deformity. So both bone graft harvest and tubercle transfers are not good options in kids with significant growth remaining. So thanks to Marcel for the really remarkable work that he's done on this. This is an example of a patient who has had a bone tendon periosteum graft taken. That periosteum extends 2 or 3 centimeters or 4 centimeters well below the tibial tubercle, and it's very thick and substantial in kids and young adolescents. It's as thick as a BTB graft, and I'll show you this graft. We're going to peel this up. So this was peeled off the tubercle without damaging the tubercle physis, And you'll see that this is very strong and very substantial tissue. In adults, not so strong. I don't know how this would be very viable in adults, but in kids, that periosteum is super thick. It's just like the patellar tendon distally there. See if this will slowly, you can see here, look how thick that tissue is, taken at least 3 centimeters below the tubercle. So you can get plenty of tissue length. You can easily get a 75, 85, 90 millimeter BTP, bone-tendon-periosteum graft, potentially for a pediatric patient. So what we still don't know is what are the biomechanics? Is this potentially a graft option for kids in the children? And I'm not advocating that we try this at home yet. I haven't done this in a human yet. I've done it cadavers, and we've got some biomechanical studies on this, comparing this graft to the quadriceps tendon graft. And Marcel and Angel have shown that in the 8 to 12-year-old knees, one, you can harvest this graft without damaging the physis, which is good news. And this graft is just as strong as a quadriceps tendon. So we all know the QT is getting a lot of attention now. Many have considered it the best graft choice. Well, it looks like this bone-tendon-periosteum is just as strong as a quadriceps tendon, so it might be an option in the future. All the sports people here know that the ALL, lateral extraarticular tenodesis, anterolateral capsule, since Clay's publication in 2013, has gotten a lot of attention. And as we were dissecting these pediatric knees, we started having questions about what is the anatomy of the ALL? What's its relationship? Is it ligament? Is it capsule? Where is it with respect to the physis? Can you reconstruct this anatomically without damaging the physis? So that led to a number of additional investigations and publications on this. But we did find that in all the pediatric patients we looked at, the ALL does attach its origin, proximal origin on the femur is below the physis. So you can reconstruct it anatomically if you do this carefully, but not damage the peripheral physis or perichondral ring, and still get an anatomic restoration of that tissue. We did find, though, that in pediatric patients, there's a lot of variation. The adult studies suggest it's almost always posterior and slightly inferior to the LCL origin, but we found there was at least 5 different patterns in dissecting knees in pediatric patients. So that was one important thing we found. The other question, Freddie Fu and Volker Musal in Pittsburgh weren't sure if this was a ligament versus a capsular thickening. So we sent them a series of specimens in which we harvested these tissues, and they did some cellular marker studies to determine, is it ligament, is it capsule, both, or neither? And they proved that this clearly was a capsular thickening based on cellular origin and cellular markers. It was not ligament. It was actually capsular thickening. And so they said this should be called the ALC, not the anterolateral ligament. It should be called the anterolateral capsule. And this was a nice paper. It was wonderful to work with Freddie Fu and Volker Musal on this, and it won an award from Isakos about 4 years ago. So really fun to do that project with Freddie and Volker Musal. So we'll talk about sort of what we've learned a little bit about patella instability. Once again, the physeal relationships, but also a better understanding of how these patellar stabilizing structures, the MPFL and MQTFL, relate to patella instability. Well, much like the ACL and other things about this, the MPFL reconstruction does have a risk of physeal rest because the anchor point is very close to the peripheral physis, and that's the most risky area in terms of causing an angular deformity. Once again, that red box outlines the perichondral ring, and that's where the MPFL origin is very close to. There's a paper from, not mine, but someone else's on JOS, and you see this is a lateral aspect of the femur, and you can see, based on this, it suggests that the origin of the MPFL is probably 5 to 10 millimeters above the physis. And so this led to an earlier study of mine. This is one of the diagrams from those papers, but using the shuttle method, we know that on adult cadaveric tissue, the MPFL is between the adductor tubercle and the MCL origin. At the time, there was no publications about the MPFL and its in relationship to the pediatric physis. And so we did some studies basically taking Schottle's technique and applying them to pediatric MRIs and pediatric x-rays. And this has led to a little bit of controversy over where the MPFL is with regard to the physis. Our first paper on this said it was just at the physis or slightly above using Schottle's radiographic method. Kepler said it was about 5 millimeters distal to the physis with some variation using MRI, so an indirect imaging study. Now let's look at this again using a modified radiographic technique, and they thought it was distal to the physis as well. And so this led to me saying, well, let's do this on real tissue. So we've got some pediatric cadavers and started looking at this. In our pediatric studies, we showed that there was a lot of variation. In the older patients, the MPFL actually was at or above the physis. In younger patients, it was lower and perhaps below the physis, but definitely some variation. Eric Edmonds confirmed our findings that the older patients, the MPFL is at the physis or above, the younger patients, it's below. So both cadaveric and fine MRI studies in pediatric patients showed there's a broad origin below, at, and above the physis in many patients. And then we published another paper with a larger number of patients in AGSM confirming this as well, even in an older patient group. We also wanted to understand where is the patella or MPFL origin on the patella. And in the adult studies, it's the upper 2/3 of the patella. We found is pretty similar in the pediatric patients, maybe slightly broader on the kids compared to the adults. And this is just a diagram of where it is on the patella with regards to the proximal and distal aspects of the patella. The midpoint in kids is probably a little bit lower than it is in adults based on that. And this has led me to kind of change the way I fix the MPFL. So I usually make a little trough on the patella. I don't want to get into the joint. I try to be just anterior to the cartilage margin along that medial border where the MPFL actually originates on the patella. Usually use 2 or 3 non-metallic anchors, depending on the age and size of the patient. And I try to orient these so that they're not going to enter the joint in any way, because that would be real problematic. And I try to make a trough of cancellous bone so the graft will heal very nicely to this. So in kids who have lots of growth remaining, though, I do a little different thing on the femur. I put anchors using the C-arm both above and below the physis. I don't want to damage the perichondral ring or that peripheral physis. And so I basically have a Y or split on the younger kids because I don't want to damage the physis in kids maybe more than 2 or 3 years of growth remaining. So I do get 2 anchors, but I don't directly injure the physis. When the kids are closer to skeletal maturity, I'll use the single fixation approach that Shea uses. And basically, you'll go across that perichondral ring, but it doesn't matter in a kid who's almost done with their growth. And also allows you to easily adjust your graft position and tension because we'll do the patella fixation later. So is the MPFL enough? For those of you who follow this, you know, up until about 5 years ago, most of the discussion about patella instability from about 2000 on was MPFL. Well, Thorkelson and some other people said, well, it's more than the MPFL. There's also this whole medial patellofemoral complex, which is the MPFL, but also the M2-TFL, the medial quadriceps tendon femoral ligament. And so here's some anatomy here. So there's the MPFL we all know well about. This is the M2-TFL. There's an extension that goes well above the joint or the superior aspect of the patella and attaches it to the quadriceps tendon. And so that led to another, well, let's look at this in our pediatric cadavers. And so this is a paper that Danica published, Danica Bhaskar, who's now a first-year resident at Rutgers. She published this last July, looking at the relationship. And basically what she found is that MQ-TFL inserts anywhere from about 7 to 23 millimeters above the superior pole of the patella. So this MPFC, this complex, is more broad than this the MPFL. So I've now changed my approach for patellar stability. So I still do the MPFL, like I've done in the past, but I'm now adding an MQ-TFL. I add another graft above that, and I sew that into the quad tendon above the patella to more completely duplicate the anatomy. So MQ-TFL and MPFL above and below. So we're getting closer to the end here. We'll talk a little bit about what we've learned about the meniscus, both anatomy, vascularity, in particular neurovascular injury with repair with all inside devices, and increasing work on biomechanics of repair. The youngest meniscus repair I've actually done, not counting a discoid menisci, is a 5-year-old bucket handle meniscus repair we published as a case report about 15 years ago. This has allowed us to, both this study, I was a little nervous about doing all inside devices because of the proximity of the vascularity. So it led to some interesting approaches to trying to figure out, okay, where is the artery, where's the nerve in these pediatric knees? Smaller knees, all inside devices may be riskier. And so our first study we did is we took our CT scans and we turned them into a series of knees. And so basically on these knees, we created 3-dimensional models of the meniscus, the artery, and the nerves. And so these green arrows kind of show those are pretty safe. You're not aiming toward the artery, you're pretty safe here. The orange arrow, you're aiming a little more. So if you're repairing the medial root or doing a root repair or a buccal handle which really goes way back there, you're pretty close to that artery, but you've got a little better safe zone there. And then of course we have the red. Anything between, I'd say, the popliteus tendon and the root laterally are what I call the red areas. You got to really pay attention because you're aiming both towards the popliteal artery, but also the tibial nerve and the peroneal nerve, which is not in this model. So keep that in mind as those green, orange, and red areas, and be very careful over penetrating with your all inside devices, or if you're doing inside out or outside in, make sure you've got those clearly protected with your retractor. So once again, that lateral aspect, and residents and fellows who've done meniscus repairs, you all know that when we're doing anything laterally, my focus and tone and attention is a little different because past pointing too far can get you into trouble. So our follow-up to this was looking at the MRI. We did this with Peter Fabricant and his group at Hospital for Special Surgery, and we kind of confirmed the same thing on the MRI. Then we did this next year on anatomy. Actually did this on pediatric specimens, not our CT models, but we actually looked at specimens, and this was published recently in the Journal of Experimental Orthopedics. And here are some pictures from that publication. And I'll just highlight this white arrow. Here's your tibial nerve, here's your popliteal artery, and this little thing right here is the all-inside needle tip that delivers the anchor. And you are millimeters away from that nerve. And then here's another one showing the peroneal nerve as you get laterally. So just be really cautious when you're putting those devices in. Now I'm going to show you something here. This is a case Dan Green sent me. This is an all-inside device. Kid had a foot drop after surgery, was referred to Dan Green, exposed the postural aspect, and guess what? Here we have an all-inside device. Both anchors went right through the peroneal nerve, explains the kid's foot drop. So you're not that far away. So everyone just be really careful when you're doing this work. It's especially problematic in the pediatric adolescent knees because they're smaller, but these same principles apply to the adult knees. The anatomy is the same, just the scale is different. So I'm going to try, and I apologize, this video won't play, but as we've been dissecting knees over the last 10, 15 years, I've really started to rethink the way I think about doing meniscus repairs, because what we're finding is there's a clear capsular separation between the back of the meniscus and the capsule and the meniscotibial ligament complex. I'll try to narrate. I've got a narration built in here, but this is a pediatric knee, and you're looking here is the posterior medial aspect. Now you're going to see this space here. There's posterior medial meniscus right there. This is the capsule. You see that distinct space between the capsule, and there's that little recess that extends below the joint line. And the Addison is pointing out that recess. So there's a space between the capsule, the meniscotibial ligaments, or the coronary ligaments, and the capsule. And so when we do meniscus repairs, we're passing sutures across that chasm. We're basically pulling the capsule to the posterior aspect of the medial meniscus or the lateral meniscus. This capsular recess is the same in the posterior one-third of the meniscus and on the posterior lateral aspect of the meniscus, or the lateral aspect of the lateral, posterior lateral aspect of the lateral meniscus and the popliteus. And so as I've been doing these dissections, it made me think, gosh, are we repairing the meniscus in a non-anatomic way by pinning it to the peripheral capsule? Does that set people up for future peripheralization or meniscus extrusion? We know that meniscus transplants, one of the greatest sources of failure is the meniscus extrudes. And so it's made me start to question if we should be doing meniscus transplant or even posterior medial or posterolateral meniscus repairs by pinning it too peripherally. And so we've started to think differently about this. I'm just going to show you pictures. Here's the posterior medial capsule right here. Red is the meniscotibial ligament complex, and the meniscus actually attaches the tibia here. It does not attach to the capsule. There's a space there. And so when I do a typical inside out or outside in repair, or with or without capsule anchors, I'm approximating, I'm closing that space between the capsule and the meniscus. And that's really not anatomic. Maybe it doesn't matter. We do a lot of non-anatomic things in orthopedics, but when I think of meniscus extrusion risk and failure meniscus repairs, it makes me wonder, is this one of the reasons we have failures? So an alternative to this would be to only repair the meniscus tear or anchor the meniscus transplant to the meniscotibial ligament complex and not attach it to that more peripheral capsule. And so the little blue suture here shows an alternative way to do this. I've done this in the lab, and I've done this in a few cases in the OR. But I'm just beginning to wonder, should we be doing this more often? And so we're starting to look at that in the biomechanics lab here with Calvin and a few others. So just to summarize, here's that capsule space, that red meniscotibial ligament complex. Here's how we're taught and how we do most, essentially all of our meniscus repairs. We pin the meniscus posteriorly to the capsule. And I'm beginning to wonder if maybe we want to change the way we do meniscus repairs. So a lot of work to come on this. Some other areas we're doing work on is we're really trying to better understand both patellar and meniscal vascularity, and had a great partnership with Hospital for Special Surgery with Scott Rodeo, Dan Green, Craig Klenner, and Ken Lynn. I'm not sure if Ken is here, but Ken has done some great work with us over the last 4 or 5 years here. We've got a lot of work going on right now is how does the trochlea develop in kids, and can we do guided growth and intervene in dysplastic trochleas to alter the development of trochlear growth? And Seth Sherman, Anthony Gaddy, Brian Koo, and Christian Wright have just been a fantastic team to work on this project over last summer and this upcoming summer. We've got a number of projects. We've got planned to dissect about 50 cadavers June 28th through 30th this year. We're going to continue some of the work on meniscus, ligament, patella development, vascularity, and repair and healing approaches. Very interested in the biomechanics of radial tears and root repairs. We've got a number of interesting studies on what's the best way to fix the tibial spine. We used to think sutures were stronger than screws, and we've shown in the pediatric tissue they're not any stronger. So maybe we need to be using more screws and sutures. Still trying to understand the development of OCD and its etiology, as well as better understand the development of the patellofemoral joint and how that might change our approach to trochleoplasty. all this work that I've done here and other places, it's just been a huge team, and I would probably have to spend 20 minutes telling you about the whole team, but lots of faculty here. It's wonderful to partner with them, including Seth, Stephanie, Robert Boutine, one of the radiologists, Steve Frick, Charles, and Molly. Scott Delp, been a great partner in many ways. Mark Levinston, Anthony Gaddy, and Marissa Lee. Kate Harbachek, one of the athletic trainers here, has driven a lot of this research and helped me run a successful clinical practice. And the lab, Hunter, Calvin, Christian Klemp, and Amishi have been fantastic as well. Had the privilege to work with several of the residents here and lots of the medical students, so it's been fantastic, and working with the undergrads as well. And also like to call out, the colleagues, Alan Anderson and Ted Ganley and so many other people over the last 15 years that have flown into Denver once a year and spent 3 days dissecting tissues and collecting data and collecting specimens for further research. So there definitely is a team effort. Last thing, I'd like to thank Allosource for donating these specimens to us. And most importantly, the families who make these remarkable gifts of donation. These are children who have usually died, sometimes from syndromes, but in many cases they've died of traumatic injury. And the families make these incredible decisions to donate tissues. And we send a letter to Allosource, which they share with the families and the donors every year, thanking them for these remarkable donations and letting them know this is the research that's coming out of these remarkable gifts of donations that you have given them. So a great appreciation to the families who have given us so much with these donations. So that's it. We have a little time for questions.
When you go from a pediatric age group, so you do an ACL reconstruction on a 5-year-old. When they're 20, skeletally mature, and you image their 2 knees, what's the repaired ACL look like from dimensional, thickness and length compared to the native one on the opposite side?
Yeah, great question. And there's repair and there's reconstruction. I think you maybe talk about reconstruction because a repair theoretically should look pretty similar, but reconstruction, you put a different graft in. I don't have a lot of experience with that, other than probably the biggest experience I've had is the iliotibial band ACLs that I've seen 5 or 7 years later, because they come back. Not many re-tear their ACLs, but many have re-torn their menisci because they go back to high-level sports. And I've been amazed at how normal the ACL looks. And I think it's partly the pediatric. You put that tissue approximately where it needs to be, and the body remodels it and realigns it and reattaches it where it needs to be. So I've been amazed with the attachment sites on the femur and tibia. And in many cases with the McKaylee-Coker procedure, where you place no drill holes, there's no evidence of the surgery that you really did because it's all gone by then. And so you can't even tell that that you put an ACL in 4 or 5 years ago. So I think the remodeling in kids is quite remarkable. I don't have enough on the older kids, because usually when I see the older kids, they come back because they retore their ACL or something else. And then you can clearly see evidence of the drill holes on the tibia and drill holes on the femur and the anchors that you put in.
Kevin, that was fascinating. Thank you. I just had a question. How do you think about if you have a child that's reaching skeletal maturity, maybe 10, 11 or something like that? What's better, given the anatomic restrictions of whether reconstructing at that point versus waiting until they reach skeletal maturity? Well, how do you balance those decisions?
Yeah, and that's the balancing point, because the risks of not reconstructing have been clearly shown in literature that after 3 months, the risk of severe meniscus injury or osteochondral shear injuries goes up significantly in kids who go back to sports. So if you've got soccer players, stop, start, pivot, accelerate athletes, the risk of secondary damage and the psychosocial aspect of the kids having an unstable knee so they can't do their sports is pretty high. So that's why we're sort of forced to think about some type of reconstruction. If the kid is captain of the chess team, and I actually have had captains of the chess team before who we did not fix their ACL or their PCL because they weren't doing any sports at all and they did okay. But most of the young kids who tear their ACLs, they did it because they were doing some high-level sport, and they're sort of that risk-taking element the kids are. They're fearless and they're sprinting, stopping, and changing. And so if you delay their reconstruction, they may end up with a non-repairable meniscus tear, which we know the biggest predictor of osteoarthritis after ACL injury is actually not the ACL tear. It's the presence of non-repairable meniscus tears. Kids who have ACL tears isolated, and even young adults, osteoarthritis progression is linked more towards meniscus damage and loss than it is towards the ACL reconstruction procedure itself. So that's the dilemma, and that's the conversation we have to have with the family and help them decide which procedure they might want to do.
Have an excellent talk. So in your talk, you have a lot of talk about precise location of the surgical drill and the surgical insertion of the implant, right? So I'm curious, in the future, will it be like a robot in the future? Because right now, robot can suture very tightly blood vessel, right? So pediatric orthopedic will be like the or robot in the future, because I think if you have like a high resolution imaging, and also you can use like a robot to really precise drill the hole and put your screw in.
Great point. And I think the role that the robot and machine learning and artificial intelligence is going to play in the art. We all thought we're not replaceable, but I actually think there's a lot of things we do. And the more precision required and the more anatomic imaging guidance required to successfully and perfectly and complication risk-free produce a surgery, that may be more and more important in the future. The cost, complexity, and implementation of robots remains a real challenge financially, but I think that's where we're going. Be interesting to ask the joint people, because the joint world is probably as far ahead of this as anyone, and the spine world is close second with surgical guidance and navigation. So. Any other questions? Very good. Thank you all.